Okay. Well, hello, everyone. Welcome to our first presentation of the year from the Center of Transformative Nursing and Health Research. My name is Marcia Campbell-Yeo. I am the acting director of the center for this year, and it is my absolute pleasure and honor to be welcoming Dr. Nancy Edwards here to us today to speak about the opportunities and careers in global health and global health research, bridging experiences from Canada and abroad. Before we begin, I'll just take a few moments to speak about Dr. Edwards. For many of you online, I see some of your names, and I can know that you have a long-standing relationship with Dr. Edwards, both with respect to collegial as well as research. And so Dr. Edwards is a distinguished professor and professor emeritus from the School of Nursing in Ottawa, in the University of Ottawa. She held the position of scientific director for the Institute of Public and Population Health through the Centers of Canadian Institutes of Health Research between 2008 and 2016. Moreover, Dr. Edwards' long-standing 4-decade career has been recognized very impressively through the receipt of 3 honorary doctoral degrees, and she is a fellow of the Canadian Academy of Health Sciences. Dr. Edwards' career really spans so much with respect to community health nursing and epidemiology across many, many countries, including Sierra Leone, Kenya, Pakistan, People's Republic of China, Jamaica, and her focus has been primarily on a topic, of course, near and dear to my heart, on maternal and child health, HIV and AIDS, and capacity building for nursing and the health human workforce. So in this presentation, Dr. Edwards is really going to offer us some perspectives around the contributions to global health equity, discuss the shift from neocolonial to decolonizing approaches, and really describe what shaped her career with respect to global health, and really talk to us about some of the narratives from her book. And I don't know if any of you have had the opportunity to read this book, not one, not even one, a memoir of life-altering experiences in Sierra Leone. So it's a fabulous book. I see that she has some here for us today. And again, without further ado, I just want to, again, welcome you, Dr. Edwards, for being with us today. It's our privilege to have you.
Thank you very much, Marcia. That's a lovely introduction. I usually just get introduced these days as grandma, so kind of hard to get used to. So I'm really delighted to be here. It's been quite a while since I've been at Dalhousie, and I was glad that your faculty had not moved. I guess I'm not good with a sense of direction, which many of you already know. I get lost easily. My mother always said, "How did you ever come back from any of those places you went to anyhow?" Because she's got the same bad sense of direction. But I'm pleased to have the opportunity to meet with you.
I'll shut this off here so we don't have to.
Making a slide
See the
adjustment here. Yeah, I do.
Just so that they don't have to see.
Very good.
There, that's better.
Okay. So first, I'd like to thank Marcia and Julie, and also Megan Aston, who wasn't able to come today, for helping to organize this, because I know at this time of the year in particular, you have an awful lot on your plate, so I really appreciated that. And I'd like to start by acknowledging the Mi'kmaq people and the territory, their territory, which Dalhousie is built on, and similar to Ottawa, where the Anishinaabe people are Indigenous leaders. It is unceded territory, so I think that's important to acknowledge. And I'm going to share today, I'm going to do a little bit of reading from the book, but not too much, and I'm going to share other experiences, particularly a couple of examples from the People's Republic of China, and I'll probably make reference to Pakistan as well, but I hope that some of the anecdotes will make it all come alive for you. And just to give me a sense of who's here, do we have faculty, students, combination? Nothing. Faculty, that was a very poor open-ended question. Staff? Yes. Yes, I recognize you, sir. Great. Great. Okay.
Faculty.
Yes, yes. And grandma. As I said. All right, so let's get started. And we'll see if how it works. Okay, so let's just start with something basic, which is what is global health anyhow? And of course, like so many things, there is no definition that everybody agrees on. I kind of like the one that says what global health is not. And global health is not public health somewhere else. But there's probably three elements that run through the definitions that are out there. One is addressing inequities. A second is that it crosses national borders. And the third is more implicit than explicit, but it's not about health care, although that's, of course, part of it. It's really about how do we achieve health. So that involves working across many disciplines and many sectors. And I think you've already pointed to what I'm going to discuss, Marcia, so you can see it there. I'll just add that I'm going to talk a bit about some pivot points in career shapers for me, and hopefully it gets you thinking about that too, and also some models of collaboration. So I think, getting into what your motives are for any kind of work in global health, whether you're doing it here in Canada or you're doing it overseas, is important. And I'm a child of the 50s and 60s. I grew up in Quebec. And what I vividly remember was the war in Vietnam. And I guess that was the first war that was televised. And I remember the images of children who were maimed during the war. And that just took hold of my heart somehow. And I decided at that time that I wanted to do something about the rehabilitation of those kids. So my first career choice was actually physical therapy, which didn't happen, won't go there. Nursing turned out to be a much better choice for me. But it was about those inequities, even though at the time, of course, I didn't have the language even to describe that. And I don't think the term inequities was being used very much then. Social justice, yes. Human rights, yes. And inequalities for sure. But inequities is really something that's sort of taken hold, I would say, in our language much more so in the last 20 years or so. I decided I was going to join CUSO, which is now CUSO International. Went to a little seminar like this, I suppose, at my university and was ready to go overseas as soon as I graduated. And CUSO said, no, 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 no. You have to have at least 2 years of clinical experience, thank goodness. So I headed off to Townsville, Australia, which is in the tropics, to see whether or not I could manage to live in a tropical country. Loved it. And then I worked as a public health nurse in northern rural Newfoundland in village fishing outports. I did end up joining CUSO after I had my experience. And just so you know where I went, it was Sierra Leone, which is on the west coast of Africa. There's a little black dot there on the map of Africa, and in the center of the screen, that's where Sierra Leone is. You can see it's a very small country. A former British colony that the British first took over in 1808. But really, at that point, they were just working in the western area of the country, the area around the capital of Freetown. And the rest of the area was sort of the hinterland and didn't become a protectorate of the British government until 1896, much later. They gained their independence in 1961 and became a republic in 1971. The official language is English because that's how the schools were structured, what we see through many colonial experiences. But there are 18 ethnic groups, each tribe with its own language. Many languages are not written languages, or they were written by missionaries at some point and made a written language as well. That was the case for the tribe of people I worked with who were the Mende. And the population, as you can see, has almost doubled actually since I was there in 1978 is when I went, and strong connections to Nova Scotia. actually, which many people don't know about. And that's one of the reasons I felt compelled to come to Nova Scotia and do this little sort of tour. And there was about 1,200 slaves, actually, that were British loyalists who had been free under the abolitionist movement, came up from the States, were promised land in Nova Scotia. The land was very poor, you know, they weren't given all that they were promised. And about 1,200 decided to go back to Africa. Many of them didn't actually come from Sierra Leone. They may have come from other parts of Africa where the slave trade was happening. But they settled in Freetown and became the Creole population, along with maroon slaves from Jamaica and some very destitute former slaves from the UK. That's Freetown. On the right, you can see the cotton tree, that big tree in the middle. That is actually where Freetown was named by the Nova Scotia freed slaves. And the picture on the left is from Forbay College, which is one of the oldest universities in all of Africa. And Sierra Leone used to be called the Athens of Africa because that. It's the first university, to my knowledge, that actually had a partnered university in the UK. It was Durham University. So that's where I first arrived. That's where we spent our orientation period in the country. So I went in part because of inequities, and there was a ton of them. And although Sierra Leone is very rich in many resources, titanium oxide, gold, bauxite, diamonds, which many of you will know about, and so on, it has not been distributed to the population. And it still remains really near the bottom of, on any indicator you want to look at amongst the poorest lower middle income country. And I guess all of us are thinking more about inequalities and inequities. I actually think this is a slide about inequities, but I stuck to what people used in the presentation of the information. And, you know, through COVID, we've seen a lot of inequities and many concerns about it. And climate change and new issues that we're dealing with are bringing on more inequities. This is a picture of a landslide in Freetown, which killed hundreds, actually. This is a shanty town built, you know, on the mountains, and they've had some terrible flooding, actually some very, very bad flooding, even just a few weeks ago, again in the rain. We know that we're going to see many climate refugees, water scarcity. This is just showing you Lake Chad up in Niger and how much the lake has shrunk to almost nothing, really, in a fairly short period of time. So I think it's important as we go forward to be thinking about the problems that exist, but the problems that are coming too, and they're pretty scary. I find them scary. I think it's your passion about global health that drives you. So just like, you know, developing a program of research and so on, really sorting out what you're passionate about is extremely important. And there's so many directions in which you can go as a health professional now, many, many more, I would say, than when I started off. If you're interested in gender responsive programs, interested in social protection, interested in women's work, interested in refugee health, there are opportunities in all of these and many, many more. So it comes down to thinking about your motives and where your passion lies, and how you're going to tackle inequities. I think if you're not interested in tackling inequities, global health is probably not the place for you. It's not to say that that's the only thing that matters, but it just, from my point of view, is just so central. And I think it takes a mix of altruism and pragmatism. So overly altruistic is, you're just going to be so frustrated. But you have to have some level of altruism because you have to be hopeful, have to believe that you're making a difference and that programs are making a difference, while having a level of skepticism to make sure that we're not going down the wrong path. There's openings for disease, determinants, and of course, population-specific interests. Some people go for the shorter term. I originally went for 2 years thinking that would be it. I ended up in Sierra Leone for 5 and then have continued on really throughout my career, but based largely from Canada. I see research very much as a tool for change. So for me, research was a way in which to address some of those inequities. So it's very much influenced my program of research as well. And I think you have to really take hold of the fact that you are a cultural outsider. Just as I was a cultural outsider in the fishing villages of Newfoundland, but you know those cultural differences where I did not speak the language and so on were huge where I lived. So let me read a story to you, if I may, from my book. And I don't know about any of you. Some of you are working in maternity child health, so this might sound stupid, but honestly, when I went to the country, I don't think I'd ever heard of neonatal tetanus. I'd heard of tetanus for sure. I've certainly never seen a case of neonatal tetanus, but neonatal tetanus actually killed about 25% of all infants who died in the first year. So it was huge. And when I arrived, within 3 months, it had nothing to do with my arrival, but it just happened to coincide with the expanded program of immunization. So we were out in the villages doing a lot of immunization work and saw some huge differences. But what I'd like to read to you is just my first experience of seeing neonatal tetanus in real life and death in a village. So to set the scene, we were in a small village called Foya, working in a barry, which is like a mud structure with a thatched roof, and that's where we had these rickety tables where we put all of our vaccine supplies and so on. It was in the evening, which was when we held many of our immunization clinics, and the women were very tired, having worked on the farm all day, probably walked about 5 or 6 miles home with their babies. Babies were sleepy and toddlers were sleeping and so on. And I was working alongside Paul, who was a translator for me and a community health nurse. I was startled by a sudden stirring and plaintive crying. Everyone turned towards the darkness as a woman emerged. She carried an infant and screamed "Swanswa," which means newborn tetanus. The baby was gripped by convulsions, its head thrown back. As the terrified mother drew close, I could see the awful telltale signs of tetanus: a clenched jaw, a facial grimace, and rigid arms. Through mournful sobbing, she breathlessly whispered that she had seen this tetanus before. She had already lost another newborn to this dreaded disease. She was inconsolable. Between sobs, she told us her infant son had been born in the village 2 weeks prior. He had a strong cry at birth, and he had sucked at her breasts until the previous night. She was so afraid he would die. She had no money to go to the hospital. She implored us to save her baby. Her dilemma was our quandary. Her anguish was our distress. Paul and I quickly conferred. Should we halt the clinic to get the baby to hospital? So many women and children were still waiting for immunizations. Chances for this baby's survival, even with hospital treatment, were slim. Still, we had to explore this option with her. Does she have her family's permission to take the child to hospital, we asked. Her downcast eyes told us that she did not. Without permission from her household head, admission to hospital was impossible. We are so sorry. We have no medicine with us to treat SWASWA, Paul explained compassionately. I was too choked up to speak. Without treatment, the infant would not last the night. I'd heard retrospective accounts of deaths from SWASWA in the villages, each told with tearful eyes and a heavy heart. Witnessing this infant in the clutches of tetanus, in the throes of death, and in the loving arms of his devastated mother stirred up a stew of emotions. Grief, frustration, anger, and empathy boiled in my core. How was it that this preventable disease dominated women's fears of their newborn survival? The loss of this infant to tetanus had to yield more than another deplorable statistic, more than heartbreak for this woman and her family. So that was one of many babies who died of tetanus. Of course, tetanus toxoid immunization for pregnant women was like a miracle cure or prevention strategy. And we headed up to the villages, immunized many, and we were starting to see a decline in rates. And we talked about prevention of tetanus everywhere we went, to village health committees, to the chiefs, when we talked to traditional birth attendants who did most of the births and so on and so forth. But somehow still, the preventive strategy was owned by us, the hospital team, rather than being owned by the community. And I think this is key. And this is a challenge of a cultural outsider. Until it's owned by the community, it doesn't really change. So one eventful day, which I'll never forget. I can remember exactly what I was doing. I was teaching in the classroom. It was really hot and sticky. And we heard the singing. That's the maternity ward on the right in the background. And these girls and women had gathered there, and they were coming across, dancing across the hospital compound. So we all came up to see what was going on. And these are new initiates within the secret society called the Sowe, the Sande Society, led by the Sowe, who is the head traditional birth attendant on the right. And she has a white head tie. That's how I know she's the head. And they had an announcement to make. I describe it in the book. And the announcement was that from now on, tetanus toxoid immunization was part of the initiation rites for young girls and women. What a day that was. That was a huge turning point. They were owning the problem. They were finding a way to scale it up. They were going to get word out to other traditional birth attendants. So there was a big lesson in that for me about that engagement and how that ownership happens. So that was a big success story. So let me move on to neo-colonialism and decolonization. I'm dry. That story always makes me emotional. It drives me up. So really, global health is a child of colonization. I just came across that in a recent article, and I think that's a really, really good way of putting it. And when many African countries and other countries were gaining independence in the 1960s, there was the UN adopted the Declaration on Decolonization. And I think there was kind of this belief that we would jump right into decolonization, and then neo-colonialism came knocking. And it's actually the Prime Minister of Ghana who first coined that term and talked about it in 1965. The roots of colonialism are deep, 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 and you don't just turn it around. And we can see many examples of how the neo-colonialism, so colonialism in a new form essentially, played out. Things like tide aid, which was very prevalent in the 1960s and 1970s. So yes, a country like Canada would give aid to a country like Angola, or name your country, but as a condition of receiving that aid, they actually had to buy our services and our products, so there would be benefits channeled right back to us. And some of that still goes on, but there is less tide aid than there was. But it's hard to get there. And I guess for all of us, we are thinking more about this decolonization here in Canada. And I think this is where bridging what we're learning from our Indigenous peoples and our Indigenous leaders and what we're learning globally and so on can really come together. And it's sad to me that I see universities where those are sort of two separate streams, when I think there's a lot more that could be learned if we somehow bring them together. I had the opportunity to visit northern BC in June, and this is in Haida Gwaii on the left. Everywhere I went, we saw the phrase "every child matters." It's talked about in the schools and communities and so on. But I visited Alert Bay, and that was quite profound for me, partly because we were there on a day when the elders were out in their ceremonial dress. It was a big sports day, and they were out in their cedar hats and their beautiful blankets and so on. But it is the site of St. Michael's Residential School, which you've probably all heard of because it's one of the CBC books that won a prize last year. And it was only demolished in 2015. That's really recently. Now, it wasn't used as a residential school until then, but it was this big, I think, 2 or 3 story building. And it just had this constant, mark on the community. It was right in the center of town where everybody could see it. And it was like this reminder all the time of the structure that had created so much intergenerational harm. So that is gone now, and what's replaced it is a beautiful cultural center where this whole story of the potlatch and the arrests that were made of the elders as a result of their holding a potlatch, which was against the Indian Act in the 1920s, is told beautifully. I would like you just to quickly read these examples and think to yourself, are any of these examples in neo-colonialism? So I'll give you a few seconds to take a look at them. Maybe those online can read the black ones, those who are here can read the red ones. I would argue that they're all examples of neocolonialism. So it takes many shapes and forms. And one maybe that's particularly pertinent and perhaps discussed with your research center is the slow uptake of clinical practices from lower middle income countries. You know, when you're resource poor and you don't have many nurses and doctors and you don't have the resources, a lot of innovation can happen. That doesn't happen here in Canada because although we've got our own problems, we're resource rich. So things like oral rehydration solution, which was developed during the cholera epidemic and well tested, and it works for cholera patients. It must work for any kind of gastrointestinal disease, but we had to kind of retest it, not kind of, we redid the trials here in Canada because we weren't sure that the trials were good enough in Bangladesh where the work was done. And Kangaroo Care, which you know about, is another example where the original work and trials were done in Colombia, but it was repeated in McMaster. So, you know, we do have to repeat trials and so on, but I would argue that part of the reason for that repetition is general skepticism that health and healthcare in other countries, lower income countries in particular, is somehow inferior to what we do here. And I think that's sometimes the case, but I think often there is real high quality care and incredible innovation that we could learn so much from. But not wishing to learn or not being open to that kind of learning, I think is a continuation of neocolonialism. And some of the neocolonialism has meant that, you know, diseases have been long neglected. Monkeypox is a good recent example, right? Suddenly it's here in Europe and in North America, and we're all over it. But it existed in Sierra Leone when I was there in the 1970s. Malaria is another one. You know, why haven't we got a vaccine yet? That's a complicated answer, but some would argue that we haven't put the resources there that we have for other diseases because it wasn't a disease recently in Canada, although it was a disease when they were building the Rideau Canal. And another example that I find kind of intriguing is chronic disease, because often we think that, you know, that's a disease of higher income countries, but lower and middle income countries have a lot of chronic disease too. The fact that a lot of the funding is around infectious diseases and not around chronic diseases is part of that neglect in a different kind of a way. So global health research, as I said, for me is a tool for change. So I see it as a way to try to improve health and health equity, but it's also culpable and can perpetuate the same health inequities that we have been talking about. I think it's really important to listen to hard-hitting messages. I can remember the first student who talked to me about genocide as with our Indigenous people, and thinking, I argue that she had it wrong. I'm embarrassed to say now, but we need the hard-hitting messages. And here's just a couple of examples. I won't go through them in detail, but pointing to the fact that, you know, global health as a field may not walk the talk, uses the buzzwords of global solidarity, social inequalities and inequities, but really we still have the power and privilege within the higher income countries. And it's privileged institutions often in the North that dominate many aspects of global health. Passports and visas, something so simple, right? But you'll remember there was a lot of hype about this with the recent HIV/AIDS conference in Montreal, with many people from lower middle income countries not being able to get their visas to come. And why was it being held in a higher income country anyhow, when the problem is so much more prominent in lower income countries? And I'd like to share an example here with you from China, where I worked in Tianjin, which is up near Beijing, on an institutional capacity strengthening initiative with the School of Nursing. But the work that honestly I really loved the most, because it's community health and what's in rural villages, was in Yunnan province. It's way down in the southwest corner of the country. And I was a Canadian project director. I had a counterpart, a very talented woman, a Chinese project director. Maternal and child health was the focus. And we were doing a lot of work through the whole health system, but particularly with village midwives and village doctors, many of whom had had no training since the Cultural Revolution. And this was a project in the 1990s. So we met many, we worked with ethnic minorities in the area in what were called poverty counties. So these are very, very poor counties with some of the highest maternal and infant mortality rates. And we had some real successes with the methodology that we used. Our Chinese colleagues did virtually all of the implementation. There was one Canadian there who helped. And we saw a 40% reduction in maternal and infant mortality rates over a 6-year period that exceeded the reductions that they were getting in counties that were funded through the World Bank. So we were excited about that, and our Yunnan colleagues decided that they actually wanted to scale this up to some other parts of China. So CIDA, Canadian International Development Agency at the time, agreed, and I was in charge of, I was on the Canadian side for the design mission, and we were exploring whether or not we could replicate this work in Xinjiang and Qinghai, up there in the upper left, and also in Inner Mongolia. So quite a large scale up from what we've done in 10 counties. And we had the design, our Chinese colleagues who had done the implementation really were doing the design with some input from us because they knew what would work in their settings. We went out and did all the field visits. Everybody was on board. We're preparing the budget. And another instance I can remember so clearly, we're in the vehicle going to another community, and our CIDA colleague says, when you're preparing the budget, you can't put any money in the budget for your Yunnan colleagues to be consultants in these other provinces. I was absolutely stunned because Yunnan province, given how it works jurisdictionally, was not going to be able to pay for their staff to go and spend time in Qinghai to do the training and so on. So they said, you can put in as much as you want for the Canadians, but you can't put it in for the Chinese. Well, the whole point was the Chinese scaling it up, who were more than capable and beyond our capabilities could do that. So in a nutshell, the whole project got kiboshed. So looking back now, that's neocolonialism. I think I'll skip this slide. It's just an example of one of the frameworks that's in there. And I think, just like that last mile in the marathon is the toughest, getting at the colonial remnants in global health is the toughest. And that's kind of where we are now. There's lots of spoken about ways that we can decolonize global health. I kind of like these examples because they're straightforward, and I think, well, they're straightforward. They're tough. They're all hard to do, but I think it gives you a sense of something that each of us can do, as opposed to something out there that has to happen at a big system level. And there's many principles for global health that have been developed and are being used as the basis for courses and so on. So a lot more thinking has gone into this, which helps us move it along. So let me now move to pivot points and career shapers. And I've had many along the way. I'll just highlight a couple that I found most difficult. I don't know for all of you what it has looked like, but negotiating a global health focus or orientation within my academic position has not been easy. In part, it's arisen out of the fact that there was a period when there was no global health research funding for Canadians in Canada. And so to get research funding to do global health work was almost impossible for close to 2 decades. So I got involved in development projects such as the Yunnan project that I mentioned to you, but trying to persuade my dean that that was a relevant activity for me to be involved in, and that it linked to my program of research was not so easy. And when the attitude, I'm not saying of my dean, but in general, is that what's going on in innovation in lower income countries is not as valuable as innovation here, that's like a double layer of skepticism, I guess, that you have to get through. But involvement in development aid projects was a huge learning for me, and I used to call it my clinical practice, which it was. So that's how I justified it. Research funding gradually changed, but just as I actually had my program of research all lined up to do work in Canada, and I got a chair award, they opened up through CIHR funding for global health research. And I was working with an organization that said, no, you can't do global health research as part of your chair award. So I had to put it on the side as part of my 25% of other stuff. So, you have to find your way through this no matter what your area of research and so on, but it's been an interesting experience in global health. And I guess quite early on, I learned that capacity building had to go way beyond the individual and needed to engage institutions. And I had the opportunity at McMaster to work with the McMaster Aga Khan CETA project, which was very much about institutional strengthening. And then as a scientific director, was able to look at how we could build levers into funding mechanisms to promote global health and the right kinds of collaborations and partnerships and governance structures that are so important to doing it properly. Civil unrest can get in the way, and I described that in the book because Sierra Leone had a civil war that went on for 11 years, which was absolutely devastating to the country. And of course, family considerations. I was married at the time to somebody who really couldn't live overseas, so that was off the table. I had to be based in Canada. I think it's really important to develop a learning plan, and I think this is an ongoing process. I would say there was a learning plan that probably went into the book, and I felt like I was developing another learning plan again, preparing for some of these talks. You can get ideas for what might need to be in there from some of the toolkits and so on that exists. This is going to be available, so I know I'm going through some of these quickly, but you don't need me to read what you can read better. I think it's really important to be cognizant of the host and their perspective on things, not just to read it from the perspective of a North American or a European who's working overseas, but how did the host see it? And so often, and especially without a formalized partnership, that dialogue actually doesn't happen, or it's just a bit sporadic and doesn't find its way into any kind of agreement about how we're going to do things properly, so there's really good reciprocity. And cultural humility at all levels of the partnership is hugely important, along with a sense of humor. Those are just a few examples about some additional training that's out there, and there's such a diversity of training programs that can be relevant. And whether you want to work in global health or not, I think these are helpful. Like, don't we want everybody to be a global citizen? Wouldn't it be useful if everybody understood a bit more about global health diplomacy as they look at what's happening in the world around us? Wouldn't it be a help if everybody knew more about storytelling? There's so many aspects of this that I think we can all learn from. And many podcasts, the TDR Research for Diseases of Poverty has some very good podcasts that they're doing these days. And also they've done good work on the ethics in implementation research. Wellcome Trust, which you may have heard of, they've worked in global health for decades. So they're a British-based organization, but sometimes these funding organizations actually have moved on developing tools that are really useful and relevant. And the one that looks at anti-racist principles, I think, is very helpful. And think about internship opportunities too, which I've rarely met nurses who've taken advantage of these internship opportunities. So I don't know if they've applied and not succeeded. I think it's more likely they didn't know. But World Health Organization, World Federation of Public Health Associations, and what we should be pushing ICN to provide these kinds of internships, mechanisms for people to get some hands-on experience in different organizations. And many funding opportunities and a whole array of new kinds of funding that's out there. And even if this doesn't fit with your particular research interests and your program of research, this is funding, for example, for artificial intelligence, I think it's helpful to kind of see what's happening, what's unfolding, and to think about the possibilities. And maybe it doesn't directly impact possibilities for you, but it opens up perhaps some avenues for thinking about some ways in which we can learn. More and more funding for Africa to take the leadership, for example, on things. This is out of IDRC looking at supporting granting councils to develop strategic communications. They fund researchers as well. We're very lucky in Canada to have the International Development Research Centre. Here's funding for research chairs on forced displacement. So this is for a variety of disciplines, as you can see. Doctoral research awards. I have worked with students who have been international students and Canadian students who have been successful in getting those awards. and perhaps some of you have as well, and awards for programs of research. And they're not all health, but boy, we need health in every one of those. It doesn't have to have the global health label to benefit from health. And the global health needs other disciplines in it to make the headway that's required. And I'm very much an advocate for, look for the new funding announcements. The funding agencies always have to be ahead of the research. Like the scientists think that they're on the cutting edge. And yes, they are, but you're kind of locked in your program and, you're building, and that's really important. And huge insights can come out of that. But the funders have to be like 10 years ahead because they're trying to fund the next era of research. So I think a lot can be learned by hearing what they're doing. Networking, I think, is really important. Networking outside your comfort zone. This is the Faculty of Law at the University of Ottawa. Networking that involves lower income-led conferences to hear how they're approaching it, the kinds of people that they bring in as keynote speakers. There's the Canadian Conference on Global Health. And so many of these events now are hybrid, right? So a big advantage of COVID. Mentorship, that was sort of always something you had to figure out yourself before, but now we've got the Reach Alliance. It's just one example of where mentors are coming together, and they are reaching out to more and more academic institutions across the world. As my first mentor, Sister Hilary Lyons, we were out one day and these twins had just been born, delivered by the traditional birth attendant, so we stopped to see how they were doing. And she was an Irish sister who lived in Sierra Leone for many, many years. And that mentorship lasted a lifetime. I visited her in November of 2019, and she died in January of 2020, just before COVID. Many career considerations you need to make, and what values do you bring? Do you want to work with faith-based organizations, or with refugees, or for-profit, not-for-profit, NGOs? Those are all things that we need to think about for ourselves. And volunteer opportunities certainly are reopening. These are just some links for you for a few organizations in Canada that offer volunteer opportunities. But there are more and more of those which are for nationals in that country, or for self volunteers like Rwanda to Sierra Leone, or Canadian international or in-house Canadian volunteers working only in Canada. So that speaks to a shift to how we move from the predominant north-south cooperation to south-south and what's called triangular cooperation, which is south-led with other NGOs, multilateral partners, and northern agencies perhaps providing some assistance at the call of the lower middle income countries at their behest. Academics Without Borders, just another example. And research opportunities, working with people who have research programs with the global element and learning the ropes that way. And contracts, such as those that appear on the UN Global Marketplace. So lots of ideas there. I'll just show you a couple of examples, and some of you may know Connie because she actually studied here at Dalhousie. I worked with her in Sierra Leone, but I asked some of my colleagues for their best advice for those interested in global health. These were hers. Think about your motives, don't sensationalize. Focus on the learning you can bring back to Canada, and collaborative partnerships are key. Judy and Tom Mill, who some of you may know, Judy worked at the Faculty of Nursing at University of Alberta for a number of years. They have worked in global health for over 12 years. If you have the opportunity to work overseas, go for it. It will change your mindset. That's really important. You don't come back the same person. Change takes a long time. Don't expect to make a big impact. Be hopeful. Enjoy the everyday surprises. Linda Ogilvie, also University of Alberta. She's really strong on context. Pay attention to it. Learn about it. Work with your colleagues to really understand it, and understand that they have and will always have a much deeper breadth of knowledge about their context than you can ever gain as that outsider. And Tricia Mark does work in Indigenous health more than global health, who talks about it being the good work you can do together with others to create change, and the need for humility in relationships to advance shared goals. So, final section, models of collaboration. And this is something that's really changed. I made reference already to thinking about the self-self and triangular cooperation. I think it's really important for us to pay attention to national and regional priorities. You know, this was the second continental report for Africa. It spells out the Africa we want. I find that the year that they're aiming for is really interesting, is 2063, because they understand what a long road this is. We're not going to get there quickly, although surprisingly quickly sometimes, but this is their agenda, and I think it's up to us to understand their agenda as opposed to the other way around, just as it is up to us to hear Indigenous people's agenda rather than the other way around. Nothing about us without us. This is somebody who's organizing that African conference that I mentioned a few minutes ago and talking about the need to collate and curate public health knowledge generated in Africa by Africans to provide an alternative knowledge base. Haven't we been hearing that from our Indigenous people for many years now? Governance and leadership are really key, and we're seeing changes in global development frameworks. Those are just a few examples, some of them framed in part around the Sustainable Development Goals. But again, I think worth reading to try to understand what some of these models of collaboration and governance models look like. This I rather like just because it speaks to some of the important issues that we need to think about in collaborative models. And something as basic as who gets to talk first, you know, and who gets to talk. These are really important questions we need to ask ourselves. We're seeing more emphasis on system strengthening led by LMICs and work being done to map research systems, to develop think tanks for in-house, in-country discussions of the key issues that people face. The Global Alliance for Chronic Diseases was an alliance I worked with closely when I was with the Canadian Institutes of Health Research, and I think they have some really interesting models that they, and partnership agreements that they require of scientists, which have been very informed by people from lower middle income countries, by researchers. And of course, we need to monitor and evaluate and see whether or not we're making a difference, and not just to expect that because we've got a new co-governance model that it's actually going to work. There are tools to assess global engagement and global citizenship. There are tools, and this one I particularly like, to assess research fairness, which really gets at the institutional level questions, and even things as basic as do the hosts get paid anything to provide mentorship for our students? What do overhead costs look like? And I'll tell you a brief story from work that I did with an HIV/AIDS program of research with colleagues in Africa and the Caribbean. And we were initially working in 5 countries outside of Canada. And for reasons I won't get into, we determined that one of the countries would not be able to continue with us. We were meeting actually all of our leaders at the Canadian Nurses Association. And we had had many discussions about the budget and what that was going to look like across the projects, and everybody was in agreement. But now there was actually more money available because of this one partner that had withdrawn. So the Canadians, like we're sitting in our territory in our association, were asked to leave the room by our LMIC colleagues who wanted to have an in-camera discussion about it. Good for them. I mean, it was probably one of the best examples I have of where they felt they had the voice and they felt they co-owned it and that they could actually ask us to leave. So we did, and they figured out how we were going to distribute those funds. And of course, we needed to be on board with that as well, but their arguments were compelling. So that was a really interesting, bit of a jarring example at the time. So let me leave you with some final thoughts. You know, I think it really is important to think about your motives when you get into this work and just rethink them because they change over time. think about how you're going to approach it through a decolonizing lens, and very specifically, what does that look like for you? And where do you see those hints of neo-colonialism, which are still pretty prominent in many places? How are you going to plug into some new networks, find some learning opportunities that work for you at whatever level of your career you're at? Where can you seek the mentors, and how do you build reciprocity? And how are you going to actually attend to the collaborative governance and leadership models? And how can we all work together to bridge learning from Canada and abroad and make this a better place for all of us? I love this quote from Nelson Mandela, who is somebody we all revere, I think. Education is the most powerful weapon which you can use to change the world. And I'll finish with a couple of thoughts that are in my memoir, where with the advantage of hindsight, I have some advice for my younger self. And I'll just read you a few examples. Take risks. Serendipity will play a part. Learn new truths by listening to others. And this one usually tears me up, so excuse me. Feel the depths of human connections. Let these rouse your compassion, your humor, your love, your outrage, and your determination to better the human condition. I think that's what global health is all about. If you're interested in this, I'll just do a little plug for a COFN webinar that's coming up in October, where we'll explore a little bit more in sustainable development goals. And I've got a few resources there for people who are interested. So I've talked a bit too much, a bit too fast, maybe with a bit too much emotion, but you're allowed to put emotion in memoirs. It's so wonderful to be able to write this way. Let's open it up for discussion, comments, questions.
Stop sharing us.
Okay.
Just up with
one.
Yeah.
Oh, yes, I see.
There you go. And stop sharing, just bring down the cursor to that. There you go.
There we go. I think that silences me. That's a good thing.
Do you want to ask people if there's anyone online or anyone here with a comment?
Well, I usually take online questions first, if that's okay. So let's just see if you've got any comments or questions from those who are joining online, and we'll take some in the room.
I was thinking Nancy over that.
So you're in the room.
No,
But we'll let you go first. Anybody online who wants to comment? Otherwise, I'll invite Meryl. The question, Kathleen, is just any questions or comments or discussions, anything that people want to react to, for those who are online first and then those who are in the room. And you have to remember to unmute yourself. Hi, Shauna, go ahead.
Hi, thank you so much for the presentation today. It was it's such an important conversation, so it's less of a question and more just of a comment to say these are really challenging discussions of how do we decolonize global health, which is so embedded in the heartstrings of many without the critical thinking. So the more that we can have these conversations, perhaps the closer we'll get to thinking about what does it look like to have truly equitable global health partnerships. You gave some really great examples. And so I encourage us as Dalhousie to continue to support these type of conversations as we move forward to have equitable partnerships. And those, which you highlighted, are not just about our international partnerships, they're about our local partnerships. And so just wanted to say thank you so much for such an important and key conversation as we emerge into deeper engagement with our international partners in whatever version of the pandemic we're in at the moment. So thank you so much.
Thanks, Shauna. And I think you're absolutely right. These are really tough discussions. There are not simple answers. But if we don't have those tough discussions, we'll never get to any answers at all. And honestly, I think, as I look back for myself, for me, like it just starts with each of us. And, that's important too. Marilyn, I think you get the floor.
No, I throughout listening, Nancy, I was thinking over the decades of your work.
I'll repeat the question in case you can't hear her online.
Yeah, over the past, well, at least 4 decades, if not more. And I know that you weren't always able to do global work in the way that you wanted to, but what for you stands out in terms of evolution that you saw in relation to neocolonialism or not?
Yeah, so what did I see that suggests that we're getting there around decolonization? I think I would say it's particularly around partnerships. I would say, and that's partly a switch from individual strengthening, probably like many of you, that remains important. And I did, work with various students and so on, and very much enjoyed it, who were doing international placements, et cetera. But moving to think about institutional strengthening, I think it's extremely important. And you can't really move to institutional strengthening until you have the conversation with your institutional partners about what does that look like for them. It rarely looks like a model that we've got replicated. It looks like something else, and ideas that we can bring back. And I guess the other one, which maybe is just an extension of that, is the co-governance and collaborative models, and true co-governance and the kinds of discussions, sometimes tough discussions, that are needed to get there. Because you just have to be able to kind of put it all on the table and sort it out through a cultural morass sometimes of different views and ideas about, who can lead and who can't, and why or why not, and institutional recognition for leadership or not, and things as basic when I worked in China, in Tianjin, of who actually held the keys for the computer room. And it wasn't the director of the School of Nursing, it was the translator. So he wasn't in our co-governance model, but boy, if I wasn't getting along with the translator who did all the translation in English for everybody in the School of Nursing, I was in deep trouble. So a lot of kind of subtle things that are sometimes under the carpet and would not otherwise be revealed come up and help us understand what's really going on and give us new insights that we can then bring to the table to find some new ways to move forward. Yes.
Well, I was just going to see if there's any more comments from anybody online.
Oh, let's check the chat if I can find the chat.
Up at the top, I didn't see anything.
Let's see.
All the way up.
There it is.
Yeah, I didn't. Oh, yeah, no.
Yep.
There's nobody online. Feel free to raise your hand at any time, but is there any comments here in the room?
I'd love to hear one new idea that you take away from this. And if there's none, that's okay too, but I'll go home depressed.
I mean, over the summer, we did a community health class, and so it's very interesting to see how you can advance those ideas to a more of a global perspective, and like taking ideas from home and pulling them abroad, but also taking ideas from abroad and taking them home, I guess.
Yes, yeah. The bi-directionality.
Yeah.
Right. Thanks.
I really appreciated being reminded, Nancy. Well, yeah, reminded, but more than that, the research opportunities, the things that we have forgotten about, or for ourselves and for students. And it's, saying that funding is difficult is easy to slip that out, but don't forget about the opportunities that you have in mind or explored.
Yeah, and I think when we're talking about students, we need to think about the international students that are mixed in many these universities across the country, and many, I don't know the number, but some for sure, will return to their country. And what's the kinds of conversations we're having in our classroom or in our clinical areas with these students that gets them thinking about their own systems and system strengthening and how nurses can engage with research funders or whatever it is, right? But that's how do we help them be better global citizens? And they're often going to be in leadership positions and positions where they can make changes. I'm not sure we're always giving them the skill set that they need, knowing there's a lot of competition for the kinds of competencies and so on that we're trying to teach in our programs. You were going to comment?
Yeah, no, I just think that I was, my voice usually projects. It's funny, when I came in today and I saw Nancy, it brought me right back to undergraduate nursing, and Donna Marr Stewart, who just happened to be online, and I bike by her house all the time and I think of Donna. And I immediately, when I think of, I think of you, never was introduced to your work was through Donna and her teachings in undergrad. And when I think of how at that time, that was my first introduction to nursing and healthcare being political and understanding that, or starting to understand that. And I think that we're in a very different place. Even when I look at my own son, who's a teenager, and his awareness. And I think that we've made some strides, not that there's not work to be done, but I do think that our curriculum is different,
Yes.
the minds around the table are different, this generation is different. So yeah, it has me thinking back to just how naive I was all those years ago, and probably wondered what Donna was talking about a lot. Yeah. And just also, I think it's inspirational to know that this is still your passion. So I think for those of us in research careers to know that you can be that far in and still fired up, that's exciting for me.
Yeah, even in retirement, right?
Glad to see you here.
Oh, thank you. Yeah, and I think, part of community health undergraduate teaching and graduate teaching too, I would say, and Donna, feel free to pipe in here, it's about a change in mindset, from the individual patient and family, which is so important, but to that broader sort of public health, population health viewpoint. And I must say that in my teaching, that's always been the most exciting thing, when you can see that mindset somehow taking hold and people are thinking of it differently. And I guess that's part of my passion in global health as well. It is a change in mindset, but we're all in that change. Some of us we've all had different experiences. We all bring that to the table. How do we look at that a bit differently? Yes.
I really appreciated your talk. I found it really interesting, very much sort of learning about this whole area myself. And new in learning about this, but one of the things I think about, so I help teams sometimes plan knowledge translation plans and activities, and who the key stakeholders should be that kind of become engaged in that. And one of the things that this got me thinking about was the difficulty to catalyze system change in Western society, in like an academic institution that's sort of founded on these paradigms of colonialism. Do you think that, I think is there sort of a responsibility, I don't want to say responsibility because that sounds heavy, but an opportunity for researchers to make sure that their stories and their learnings from these experiences come back and show the institution sort of what we've learned and how to engage with communities around the world. And then a part B to that, do you think the institution's ready to listen and to change and to, like, are we there yet that we can actually break down some of these barriers?
So that's a great double-barreled question. I would say that from what I've seen, there's probably been more emphasis on knowledge translation as it relates to making sure that the knowledge that is generated in a country of Nigeria, Bali, wherever, Indonesia, whatever, is in that the country has that and is part of not just creating that knowledge, but of interpreting it, making sense of it, sorting out what they're going to do with it, and so on. I think we've gone a long ways to figure out how to do that better. But I don't think we've done a good job of bringing it back to our own setting. And some of it, I think, is because sometimes global health is kind of this specialized area out there, as opposed to something that we see as being important to integrate. And my view on that is, I presume, obvious by now. But I think we need to think about how we can co-construct knowledge translation approaches here that bring that incredibly valuable knowledge and innovation, and show respect for it. It's the same with Indigenous health. Like, why wouldn't we bring that learning into our curriculum? And I think we're doing better than we were, but we've still got a long ways to go. And I've already forgotten your second question, so I apologize. Did I get it? Oh, systems being ready, yeah. Well, I would say that's something that acts as a bit of a barrier to that. And I'm not speaking about Dalhousie because I don't know your situation here, but I've seen this in some other universities where there's been a lot of push and emphasis for internationalization, which sometimes in an internationalization office largely means bringing in international students, which bring in extra high tuition fees. And that can be at odds, I would say, with some of the values and principles that we're talking about here. So, I mean, that may be a monetary reality, but it may not be the office or people we need to work with to move forward on the kinds of system change within our own curriculum and so on that I think you're talking about. Yeah. Oh, did they? Interesting. I need to learn more about that. We can chat.
So there's just been so much conversation, of course, because of fantastic presentation, Nancy. And some of the things that resonate with me definitely is talked about humility, listening, working together, learning together, things I think we can do every day here.
Yes.
Amongst all of the people that we engage with, both at home and internationally. I just want to thank you again for your 4 decades of amazing work. I'm getting emotional about what was in your book and your experiences, what you've contributed, not just in your work, but also in your leadership through the CIHR and the various levels that's actually made change in some of the ways that funding and organizational things, it's really helped make a big difference for all of us.
With many others, of course.
Yes, but I think that it's important to note that, we see that in the way that the funding, some of the things that's actually been put in place, structures to help with decolonization.
Yeah.
And so again, thank you so much for all of your work. Thank you for being with us here today. And I think if it's okay, we'll be able to post this on our Center for Transformative Nursing Health Research website so that people will be able to come back and see those fantastic resources. Thanks to everybody for joining here in the room and for joining online. And take care, and we'll be seeing you at the next center webinars. Take good care.
Thanks very much, everybody. Glad to have had you online. I'm not going to take responsibility for that.
Yeah.